everyone, and welcome. Thank you for joining us today for the Clinician Experience Problem, removing the administrative burden that slows healthcare down. My name is Sarah Bishop. I'm the Chief Operating Officer at Mockingbird. I've spent the last 15 plus years of my career working alongside healthcare organizations and clinician licensing teams. I'm excited to have this conversation with all of you today. Little overview of what we're going to be discussing. Healthcare organizations are under constant pressure to recruit and retain clinicians, improve operational efficiency, and deliver exceptional patient care. But one challenge that's often overlooked is the administrative burden clinicians face every day. From onboarding and licensure to compliance tracking, continuing education, and managing state-specific requirements, administrative work creates friction that slows clinicians down and contributes to burnout. It also impacts the organizations working to attract, retain, and support their workforce. Today, we'll discuss why the clinician experience has become a competitive advantage, how operational complexity affects both clinicians and healthcare organizations, and what leading organizations are doing to reduce administrative burden and create more efficient workflows. This is a 30-minute session, and we want to be mindful of time. So if you have any questions throughout the webinar, please submit them through the chat, and we'll answer as many as we can at the end. With that, I'd like to introduce our speakers, two of my favorite humans and physicians, Dr. Ian Madom and Dr. Mark Shen. Ian, would you mind introducing yourself and sharing a little bit about your background?
Sure. Thank you, Sarah. And I appreciate our team for putting this conversation together because it's a really important one. My name is Ian Madom. I'm an orthopedic spine surgeon. I'm sitting in one of my clinic rooms right now because I do still practice pretty much full time. I have spent 20 years in healthcare delivering care to folks, and a number of years ago, back in 2018, joined forces with another doctor to solve one of the administrative burdens that we feel as clinicians on a regular basis, which is managing and keeping up on all of our certifications, especially licensure. So that's a little bit about me, and we'll get into more about what my thoughts are on these kind of burdens in a minute. Mark?
Perfect. Yeah, Mark.
Thank you. So again, my name is Mark Shen. I think it's easier to maybe say that my career has had kind of two halves, maybe three halves. I know that doesn't add up, but the first half, I was an academic pediatric hospitalist, very interested in quality, value, teaching. And then the second half, I've been on the administrative side, as I call it. I've run two children's hospitals, value-based care for an Ascension system, and I currently run a small surgical hospital, working with doctors actually like Ian, doing a lot of orthopedic and spine procedures here in Austin. And but I've also had the fortune of working with Sarah at digital health companies like Babylon, but also Walmart Health for a period of time as they were trying to build both physical clinics attached to super centers as well as digital infrastructure. And so I've kind of seen this grow tremendously since the time of COVID as well. So excited to be here.
Amazing. I'm so excited to see the two of your both backgrounds and the dynamic and conversation we're going to be able to have regarding all of this. So Ian, I'd like to start with you as both a practicing physician and a healthcare leader. Why do you think administrative burden has become such a significant challenge for clinicians today?
Well, I mean, it continues to just grow, right? It just like we've been talking about this ever since I was back in medical school, that the the increasing demands that pull the clinician away from the bedside. And that's the bedside, like in quotes, right? Like it's people on this call have been in an interaction being seen for something, and the person is looking at the computer, right? And not looking at them. That's administrative burden, right? In real sense. They have dealt with somebody that they've called to get an answer on a question and they don't hear back for days. That's because the person is underwater with the amount of stuff that they need to do, whether it's the CME that they didn't know that they needed to do or some other kind of, administrative thing. These problems continue to grow, and it's not like the technology hasn't been there, but the the attitudes for it have been in the past. That's the doctor's problem, right? That's the NP's problem. And I think that since COVID, we see that those attitudes are shifting because there's a lot of people leaving the profession. And and if you're going, and now we're a scarce resource, so that now everybody wants to make sure that we stay on. And they're starting to realize that they got to pay attention to some of these problems. And we're not asking a lot. We're just asking to get back to doing the thing that we love to do, which is taking care of people. I don't know what you think about that, Mark, if there's other aspects of it too.
Yeah, no, I hear you. And I think this theme of like it's growing, and I'd add that it's one of those things where it grows silently, and then you suddenly realize that things are so different from kind of what you really, went into this profession for and how things were way back when. So I mean, I think you and I are probably, similar age and experience. And I remember like when I was in training back in the day, our attendings would literally come in and write agree with above, right?
Yeah.
And you focused on teaching and going to look up articles and all this stuff. And that's transformed to today where, clinicians take home their note writing, right? They log into the EMR at home because they don't have time at work. And every single detail of the medical student note to the resident note to the attending note is all designed around this administrative burden. And there's so many more things to think about, but it's been kind of slow and insidious, right, over 20 plus years. And then you realize that you're not doing as many of the, fun, enjoyable, rewarding things, or it's been squeezed because you have this administrative all these administrative tasks hanging over your head every day. And so I just call out that I think that kind of subtle, almost insidious growth of these tasks is there. And then it manifests in varying ways in terms of burnout and surprises when you forget to do something.
Yeah. Yeah, I think that I think of those are the topics that I think of. Like there's these three big buckets that I think about when it comes to administrative burden that I see and that I've been tracking over 20 years. And one of them is this like in the clinic, the documentation, as you said, like it used to be. I'll one up you. My father, who was a pediatrician for years,
Oh,
I remember going into his office and seeing his notes, and it was like, positive strep culture, and then writes the antibiotics, follow up 2 weeks. Like that was the note. And
yeah.
obviously, like that doesn't, like there needs to be better documentation than they did back in the day. Like it helps patients. But how do we do this now? So, helping people do their documentation in a real-time way so they get away from the computer. That's a big administrative burden. The other one is, prior authorization. We talk about it, that it just adds to the amount of work that clinicians have to do. And how do we get people away from doing peer-to-peer calls or not getting the care approved that really follows the right guidelines? That's another piece. And then the last one is something that we work on at Mockingbird, which is just all this pajama time we spend doing our education, which is important, but I will question whether it's really educating us in that setting where you feel forced to do this, piece of this certain piece of education that teaches you something in a very defined period of time, but doesn't really necessarily fit into your practice. It's just done. All of these things we're still holding on to these relics of how everything used to be done, but we've instituted new requirements and new platforms like an EMR, like a reporting structure on the state, like it's all these different things that you have to do, but no support on the back end on trying to accomplish them, which really makes it challenging. So that insidious nature really comes about by all this new regulation coming down, but then nobody supporting the infrastructure from the bottom side to be able to deliver on those requirements anymore.
Yeah,
Well,
and if I could just add, so I didn't mention this in my intro, but I have 51 medical licenses, 50 states, plus Washington, D.C. And I practice a little bit through telemedicine, but primarily what I do is I help digital health companies that are delivering clinical care. I help them scale across the country. And so just as part of maintaining those licenses, to your point, Ian, like every time I renew a license, I kind of brace myself emotionally for a potential surprise. And like I'll call out Michigan. No offense to the medical board of Michigan, but I remember I was renewing one year. I'm like, oh my gosh, I have to do an implicit bias training. I mean, yes, I appreciate the importance of implicit bias. And it's great that states are latching onto this. But I was like, oh, one more unique thing. And, it's specific to the state of Michigan, and recently some other state caught on and is trying to do this. But, it's just one out of 51 different jurisdictions that is going to require something of me. And that just adds up. And again, like it's, I would bet there is no physician that sits out there going, okay, let me plan and just stay on top of all of these state regulations for what changes and what's the flavor of the month in terms of requirements on me. And it's funny I'll just say when you renew, like a lot of times they don't spell it out for you. They just say, go to, this state regulation and look it up. And you have to read through kind of legalese to understand it. And it's not what, again, we want to be doing with our time when, we imagine this coming out of med school.
It's really where they've again that increasing requirements in all aspects, reporting requirements on your documentation, right? What's involved with MIPS this year, like what's involved, like you can't keep track of all, like the thing that a patient wants me to keep track in my head is what is the current standards of care for their spine, right? They don't care about this other stuff. I mean, they do, they don't realize it because we should be focused. These things are still important, but there's just a better way to do all this stuff. And I appreciate now that, I mean, we've noticed it at Mockingbird, and I'm sure you have too, that larger organizations are starting to bring on some of these platforms and technology to support it. I mean, there's a financial reason there too, right? They're like, okay, we have to focus on that. And part of that is retention. It's so expensive to churn a clinician rather than just keep them and continue to support them. And I think that the financial piece, that financial, I guess, evidence is there now, and hopefully people's hearts are following behind that. Hey, we're also doing the right thing here for our clinicians.
but even then, so the money is time, right? Or time is money. So you're spending all this time figuring out which class to take. How many different opioid classes did you have to take to renew all of your licenses? How many different child abuse courses? How many different implicit bias courses? When, we may be able to tell you this one, if you take this one opioid course, it's going to take care of all these other states. So you don't have to go searching for 5 different courses throughout the course of your year of renewals and everything. So I see that all the time with that burden. I'm curious I see a lot more companies trying to find ways to improve the clinician experience, and using, tools for recruitment, retention, and operational success. Why do you think that's such a critical need right now?
Yeah, I'll start. So I mean, I think, as we talked about, the burden just continues to grow. And by the way, I'm fresh off of kind of a parallel in life. My daughter just turned 16 and passed her driver's license or her driving test today, but then in order to get her license in Texas, my wife was the one kind of certifying and attesting to all these things. Like we went through a whole thing this morning that I have to somehow prove that my wife lives at our address. And it's this whole thing of things like, I thought it was going to be easy. She passed the test and she gets her driver's license, but no, it's not that easy. All these things have just kind of grown in terms of our responsibility now that we have a 16-year-old, and it feels the same way in kind of medicine. So I think as the administrative, like, right, it is not decreasing, and you have to I kind of probably face this on different sides of the coin with just trying to get paid by insurance companies, right? All this documentation, like on the hospital side, it is so complex. And so, as that burden continues to grow, I think like you have to systems, everybody involved in the process has to find ways to help minimize that burden, especially again, because as we talked about, kind of this whole time money aspect of physicians. And, we really probably should go to another level of, and Ian brought this up, right? The patients don't care about any of that, right? They want to see that you're not like focused on billing and dealing with insurance companies. They'll get that, but they'll be frustrated by it too. They want to see that you're being attentive to them and can explain and understand the latest, which is also evolving in terms of medical knowledge. And so I think there's a huge onus these days on systems that continuously find ways to streamline that. And I think probably one of the best examples of technology that has grown rapidly, although in many other areas, I think there's just barriers. But, I think kind of whether you call it just dictation or AI models like a bridge, right? That's fairly commonplace
Yep.
now, and it's kind of alleviated some of that burden in a good way. But again, that's just one kind of little snippet, and I'd say there's so many other areas where there's many complex tasks, lots of paperwork to do. And so I think there's tons of opportunity to continue to do that. And clinicians will respond favorably if it's really helpful.
Yeah, I mean, it's not a pizza party, right? Like that's not how you keep clinicians. That used to be,
Yeah.
it was if you feed them, they'll be okay, right? But it's not that. And I think that was a good example, like the AI platforms that do the scribes, right? Like, a Bridge and other folks that are out there that are integrated into EMRs. It takes you away from the computer in front of the patient. It's recording the experience. It puts you in this situation where now you're not repeating work, which is oftentimes the way we feel like we get grinded down when we're having to do repetitive tasks over and over, and it's not really impactful on the patient outcome. The challenge that we face, at least for us in Mockingbird and other folks who are doing the licensing and is the AI space is really challenged in highly regulated areas, right? Like when it comes to anything with the government, because they have all these firewalls and you can't just workflow your way out of some of this stuff. And so some of the stuff that we're using some AI tooling on the back end to accomplish some of this stuff, which the clinician doesn't see when they're doing the stuff, the admin that supports us isn't seeing. It's on the back end, so it helps some of the platform run better. But there is a part of this that, until regulation changes and the law has to catch up to AI, which it's like scrambling to, chase after, that part's not going to get fixed in the highly regulatory space. So it's still reliant on these employer and let's think about it. Like the majority of clinicians are employed, right? We don't private practice, true private practice, maybe physicians like at this point, I think it's like 30%, and that might be even high right now, are independent clinicians. So leaving, the number 68 to 70% of people who are employed, we're relying on large organizations coming to the idea that that they need to bring on technology and technology that supports their current admin staff to help us and the clinicians to be able to make this stuff go away or at least streamline it for us in a way that keeps it organized, doesn't pull us, again, at home doing work in front of our laptops because that's what people don't see. They see the stressed clinician in the clinic taking care of them, but they don't see the hours of work that they did at home that night while helping their kids do their homework, while trying to get, a meal on the table and then to get to bed at a decent time. Never mind, maybe do some exercise and take care of their own health. All of that stuff starts to get peeled away. Those are the first things that go. Is the first thing that go is I don't have time to exercise, right? I don't have time to eat right. I don't have time to go see my own clinicians or go to the dentist. I don't have time to get to my kids' practice or game. I don't have time to do that. It's in that order. I think that's been for me, right? Those are actual personal accounts of things that get peeled away because you're at home doing the work of all these additional administrative tasks. So thank you to the organizations out there that are seeing that and are starting to bring these things in.
Just keeping an eye on time here as we get closer to the end. I just wanted to end with an open question of what advice would you give clinicians whose organizations don't yet prioritize improving the clinician experience or reducing administrative burden?
I mean, I would point to so Don Berwick wrote that big article that everybody focus on the triple aim, and people have called it into question, like, have we really gotten into hit value-based care, and have we really gotten into figured out what value is? But it's still important. We know that the system doesn't function without improving the idea of population health, improving the patient experience, and adding value, right, of what the care that's delivered. But that fourth pillar that was added right after by this group out of Harvard, the quadruple aim, not the triple aim, valuing the clinician experience cannot be understated because when it comes to churn of clinicians, that's a dissatisfier for patients. That's a expensive thing for you to undertake. And it's a small community of people. Like we know who the actors are that don't focus on how they treat their clinical workforce. And we have, as clinicians, a unique skill set, right? We went to quite a bit of schooling to get it. We pay quite a bit to keep it up and to continue to do it. And really, I would say the vast majority of us are driven by one thing, helping people. We just want to make people better. So just, the little Jerry Maguire moment, like, help me help you, right? Like, just give me some of the tools to let me do my job better. And doing my job better is really focusing on the patient.
Yeah. And then I add kind of almost a primary care context. Ian, as you were talking, right, you talked about the limitations that this burden has on kind of maintaining your own health in a way, right? And getting back to doing those things. I think there's also some of these surprises that can happen. And again, I'm thinking back to my own license renewal, right? I think the whole mantra of an ounce of prevention is worth a pound of cure is very useful because if I'm a clinic, or hospital, and I have somebody like you working, and if for some reason like something happens with your license and you get tripped up, right, that impacts all of us, and that's very significant. And I can remember a specific state, I won't call it out this time. Sarah and Sarah probably remembers this, but a state with these weird kind of you had to do a separate thing and prove insurance and pay to another fund, and that kind of I didn't notice that. And then I got investigated by the state board, right? And so suddenly I had to disclose when I was renewing other licenses that I had been investigated by a board because I missed this kind of, it was a unique state that does this thing, and I had missed that process. It was also during COVID, and they didn't do an email notification, so it was buried in like the 5 pages. Welcome to your license. I didn't notice it. But I go back to that, and now I'm like terrified of those situations because I don't want extra administrative burden that could have been prevented if everything had been kind of lined up for me up front. And again, I was doing this on my own at the time and didn't have a ton of support, and it was missed during a chaotic COVID period. But I think systems have to, I think clinicians need to be able to advocate to systems that, again, the more upfront prevention that they can do to help with the clinician experience, make this seamless and easy and efficient, they will be preventing lapses on the back end that are going to, harmfully impact everybody.
It's funny, Mark, because I actually spoke with the medical board of that state at the
Oh.
FSMB conference this year, and I mentioned that your scenario. And they said, I don't know why these physicians miss it. It's in the email. And I said, the email's so lengthy and it's in the bottom of the email, and you're expecting them to read the email in its entirety when it's the first line is your congratulations, here's your license. So they're like, great. And they say, well, they should read the whole email. And I say, well, what if they're licensed in 50 states and they're reading all these emails? And how many emails are they getting? They're thinking about their one state. It's in the email. We did our part. We checked the box. All I'm worried about is what my state's requirements are, not what else is on that clinician's plate, and it's our responsibility to have to make sure they did it and everything. And I know our team at Mockingbird spends a lot of time on the phone with boards and clarifying rules and CME requirements, and even saying, hey, this is in your administrative code, but it's not on your website. Oh yeah, the website's not update. The administrative code is what's correct. How many clinicians are reading administrative codes on the state boards? I don't think that many. So
No,
how are
it's
they
like I
supposed to?
have no idea what the if I don't know what the requirements on my documentation are unless somebody gives that to me. I don't know what the insurance plan needs for me these little minutia checks to actually do the surgery. It's the same thing. It's like, we'll do it. We'll do it if you just give it to us in a way that's
Yes.
digestible and easy for us to keep track of, and that it just puts it in front of us at the right time for us to take care of it, because there's a lot of things going on up here.
Yeah. And Sarah, let me just say, I think that's a great story that you just shared because it illustrates that you almost need like a multi-pronged approach to
Yeah.
solve this, right? Because nobody's kind of thinking of it that way. And so I would just say, thank you for advocating on behalf of us clinicians to get that message across. Because it feels, to Ian's earlier, it feels like you're dealing with this big government regulatory thing that just, doesn't see you at all. But it's important. It's important to everybody to kind of make it easier and improve that experience.
Yeah, and I feel for you all. I don't know how you do it. I don't know how you track it all. And I would rather have you focusing on patient care than this
Well,
silly, finding a sentence in the bottom of an email that says you have to do one extra task. If we can simplify that and say, also do this, then that
like Mark said, because of you and your team. So thank you.
awesome team at Mockingbird. And I am seeing that we're at time now. So thank you both for joining. This has been an amazing conversation. We appreciate you both for your very valuable time, for stepping away and taking time to talk with us and advocating for other clinicians such as yourselves in the same boat. So thank you for your time, and I appreciate everybody attending.
Thank you, Sarah. Thanks, Mark.
Thank you. Yes, thank you both.
Cheers.